So when this started, we'd actually got on to about year 2, so we were coming to the point of implementing it. So today's session, as it says, we'll cover station setup, paramedic training, quality control, and then some implementation methods, but we'll also talk about the barriers as well. So our aims overall were, firstly, can we do this in a pre-hospital setting for an emergency ambulance? Can we look at the impacts of pre-hospital troponin testing? And can we look into a pathway of treating some of these patients? So your very low-risk patients, can they go to their own GP? Your very high-risk patients are non-STEMIs, as James mentioned. Can we take them directly to a heart centre? And that's what we started to look at. So spiral alert, we can do it on an ambulance because we've done it for the last couple of years. The evaluation of the cost fundings and pathways and stuff is ongoing. So station setup, we started off in Manchester Central. So if anyone knows where that is, it is literally a stone's throw from MRI A&E. You can literally hit it if you can throw it hard enough. We started off with about 29 paramedics. And then after a short period of time, we moved over to Duckingfield and Ashton. And as it says there, we trained 74 staff members, so 74 paramedics in the use of the troponin device, which was the Siemens Intellica VTLI, and the use of the TMAX. Paramedics were recruited on a volunteer basis. We did incentivise them with overtime payments to come to do the training. As we talk about the diagnostics care, that was also overtime. As we talk about the station setup, that picture is of the response bay at Duckingfield Ambulance Station, and it doesn't actually do the space justice. So when we talk about barriers, how much space that actually was. So just give you an idea, from there to about here was the space we used. And as you can see, there are 7 devices, 7 fridges, large fridge, large freezer. So it takes up quite a lot of space. Training, as I said, we trained about 75 staff. Initially, we had face-to-face sessions where we used staff from Siemens who would come in and do detailed training sessions. We had an ECG tutor who was a colleague of mine who trained taught at university level for ECG recognition. And we also went through pathways and went through feedback methods as well. Shortly after that, we developed self-directed learning, which we used Microsoft Teams for. This covered all aspects of the training and also give clinicians remote access to the training materials throughout the pilot, as well as a method of communication through the chat system. We use both purely because the nature of paramedics is shift work. People don't want to come in on the day off, so it meant that we could reach a wider group of staff. And it also provided a medium, should someone not do a troponin test for a period of time, they can refer back to it, and that learning is still there. And also there's that constant form of communication, should they want to feedback any incidents that they'd undertaken or any feedback they wanted to give. So this is the equipment that we took out aboard an emergency ambulance or on our diagnostics car. So you can see the VTLI. Just to point out with this, the VTLI has been discontinued, but it's important to mention that this wasn't a test of the VTLI, it was a test of point of care troponin testing in the pre-hospital setting. It just so happened that when we were looking at the devices, as part of my predecessors, this device fitted the emergency setting better. It was smaller, lighter, and had the quicker test rate. Along with that, you can see there's a small fridge at the back. This was battery powered. And the reason we had that was because the cartridges we carried had to be kept within a cold chain between 2 and 8 degrees. They will last outside of the cold chain for 24 hours, but if we wanted to use them again, this had to be maintained throughout the shift, and kept in that fridge. And as we talk further on about our barriers, this was one of the largest ones. Along with that, we had wider bore safety lancets. So if anyone's ever had a blood sugar test, what we prick your finger with, it was one of them. Just the needle was bigger and created a slightly bigger hole. Hurt a little bit more as well. We had some pipettes that we collected the blood with because we were using capillary testing only. The device did do venous, but as we talk about the barriers, I'll touch on the reason we chose venous. Capillary over venous. We had the cartridges, and the case was an open house carry case, which was designed to allow air to be drawn in by the fridge to continually cool, and was also lined with the same things you put your lunch in to help maintain that cold temperature. So the clinical pathway that we used, as James mentioned, we didn't change our established pathways within MWAS. So chest pain patients predominantly go to hospital. We can maintain that focus that the safety of the patient came first. So just to talk you through this, an ambulance receives a call for a chest pain patient. The crew will arrive on scene, they'll do a set of observations and an ECG prior to doing the troponin test. And this is because we don't want them taking the time to do the troponin test without understanding whether they meet the PCI criteria or whether there are other observations that are deranged while they would just need to be taken to hospital. Just to give the example, a PCI patient doesn't need a troponin test, they need an angiogram. So we don't want to be delaying that patient treatment absolutely any more than we have to. So your crew will arrive on scene, they'll do your ECG and they'll do a set of observations to make sure the patient is safe to stand the test. We'll take a capillary blood sample, we'll insert it into the VCL line. It will take around 8 minutes. As Rhiannon will touch on when she talks about the more data side of this, initially we started around about 15 minutes to take this test, and we got it down to around 9 minutes as staff got more and more used. They will then complete the TMAC score, as James mentioned. This was very simple. Yes, if it was present, no, if it wasn't. This give you a score at the end, and then they would add the troponin figure, which then give you a risk percentage. They would then take a media shot of that risk percentage along with the breakdown of the TMACs, add it to their EPR, and then they would carry on to hospital as per their standard pathways. After completing the incident, they would then feed back via MS Forms, and so that would give us the incident number, where the patient went, how they got there, and any other feedback they wanted to provide. As I said, we didn't change anything to the existing pathway protocols. We didn't test on PCR suitable patients because, as I said, they don't need a troponin test at pre-hospital, potentially need an angio. And we made it very clear within the training that ACS is not the only condition that could give you a raised troponin level. Chronic kidney failure is what, for an example. So this is just a TMAX breakdown as we used it. So as you can see there, it's a point for yes and nothing for no. Work our way through them questions, and then we add the troponin figure in at the end, and that will give you one of the 4 categories there. No, again, not wanting to go into the data stuff because I don't want to step on Rhiannon's toes. We had a slight change with the response to some of our paralytics for our very high results. So if they were 100% risk, we added into the standby procedure that they could take the patient in on blue lights under what we call a stage 3 standby. Whereas they make their way to hospital under blue light conditions and then inform the triage staff of the results as part of their handover. So hospital handover, we had Manchester Royal Infirmary and Tameside General Hospital who were part of this pilot with us. Obviously patients went to different hospitals, but with these 2 hospitals we would follow the patient journey through as the paramedics fed back that they took a patient into MRI. Using the incident number we can then track that patient's journey through the hospital. The idea being we can see if they went in with a very low risk score, what was that treatment pathway, what did it look like, did they have an ECG and a single set of blood tests and sent home, can we replicate that process in time? Patients that went to other hospitals, we still handed over the information because it's still usable information, it's just we didn't follow that patient journey through. As it says there on handover, the clinicians will give the TMAX risk score, so not just the troponin figure in isolation, because you don't get that full breakdown, and they added the breakdown itself to the EPR system, so it can be reviewed later. Hospitals can then decide whether they want to stream the patient based on the results. So could they send them to the SDEC, which is same day emergency care, which is exactly what it says on the tin. It's can you be treated in the day? Or do they need to go into resource for more enhanced treatment, or can they go to a different area within the hospital? The QC process, especially with the Siemens device, I can't comment on the others because this was the one we used, was quite extensive. So it had 3 levels of the manufacturer's own QC, and then 2 patient samples that were provided by NEQAS. So that in total is 75 tests per month, and that's if they pass first time. I did end up calling them like petulant child at times because they misbehaved, just like my kids do. In order to complete this process, I looked at different variations of what we could do, how to run this QC process for all the devices. And in the end, we decided that we would just collect them all up from the 3 sites that we operated from, do the test, and then return them in a day. This meant that there'd been minimal removal of the devices, and it was also the most economical with regards to the QC testing files and the use of cartridges, and my time as well, because it was just myself and I didn't have to drive around 3 days to do what I could do in one. Any results that were outside dedicated parameters, or designated parameters, sorry, the device will be removed from circulation. We had a really close link with POCTT MRI, where all the results were, including the EQA, would be fed back and they were collated and then reviewed, and anything that was out of the norm, we'd be informed and could remove that device from circulation. We always kept 2 or 3 devices spare, just in case we needed to swap some out. And I don't know if Jessica is still here. Jessica was our POCTT lead, sorry, for MRI. So, potential methods. So when we looked at this pilot, it initially started as just on an ambulance. Like I said, we didn't change any dispatch methods. We didn't want to create an emergency chest pain ambulance because that would create a disparity in treatment. What we ended up looking at was an ambulance method and a diagnostics or RRV method, and then what were the pros and cons of each. So we'll just go through them with you. So the ambulance, we can reach a wider group of patients because we'll train all paramedics. It would obviously mean a larger training pathway, but would be a standardised approach in care across the NWAS footprint. This would obviously require large-scale training. As I showed you the size of the RV bay for Ducky Field Station with 7 devices. I always pick Wigan Ambulance Station because I live in Wigan. That has 20 plus ambulances, several RRVs. So the logistics and the estate side of implementing this on for ambulance wide are quite extensive. There's also the cost of the devices. It wouldn't just be one on every ambulance. We would have to have spares. So there was additional cost with that. And then obviously you need cartridges and QC solutions that would need to be run regular. And as we've discussed, or I've discussed, the QC requirements will be expensive and extensive, and it would almost result in being an individual role that we would have to implement across NWAS. With the response car, so manned by experienced staff, and there's a couple of the guys who are in the audience today, Ben and Nigel, who ran this car with us. We also had some advanced practitioners, which included myself and some from our urgent care team. So you get that really high level care that are specifically targeting chest pains. So it increased our opportunities for see and treat. And it says alter, it just means alternative to transport, so alternatives to getting an emergency ambulance. So can we use private providers? Can we send them in their own car by loved ones? Can we get them in a taxi? All based on their clinical presentation. Equally, you get that earlier assessment of your very high-risk patients by experienced staff. We're able to specifically target chest pain incidents across the Greater Manchester footprint, which increased our utilisation daily, rather than being open to any and all incidents. And having it on a single car or a smaller number of car obviously reduces the logistical burden and costs. The negatives to having such a car is a smaller patient group that we can reach because we can't reach everybody. And there's a potential for a differentiation in care because we can't provide that level of care to everybody. Whereas with an ambulance, if we treat everybody in it, everyone should get that same level of care. So I don't work in an A&E, but we tried to put this together just to show the benefits of in a working or what it does for a hospital. So talks about SDEC, so direct referral to same-day emergency care teams. So more probably for a very low and low risk or low and moderate, can we take them in and have assessment within a day? So we're not taking them to main A&E. Rapid transport of high-risk patients who don't meet the PCR criteria. I think this one's further down the line. It definitely requires more work before we would start messing with the operational aspects of PCR labs and increasing beds and things like that, certainly outside of my remit. Equally, could we use the risk scores for NWAS procedures that we have now, like fit to sit? So your low-risk patients, they don't need to be on a bed. Can they be put in a chair, handed over to reception as we do with some patients already, or call before convey. And then in hospital uses, this has been touched on a bit today. So there's the iCare Faster pilot that Rick mentioned, and Best 2 around reducing pressures in A&E. I sat through one of the presentations by Martin Than, if I got his name right. And he said they basically, a chest pain patient would come in and they would test that patient using a POCTT device almost immediately while running the lab troponin 2. And if they were left of a certain level, they would get them out to the cubicle, free that up for somebody else while still awaiting the test results. So just freeing up beds, easing the pressures on E&E. And as we've mentioned already, hospitals can use the results to make decisions as to whether to stream patients elsewhere. So barriers around this pilot. So cartridge storage, as I mentioned, the cold chain was probably our biggest barrier in maintaining it. It did result in quite a lot of wastage because it was difficult to maintain that 2 and 8 degrees on board an emergency ambulance, especially during the summer. The paramedics that are in the room can attest that the fear boxes get very hot, even when it's quite mild temperatures outside. 27 degrees outside is probably about 30 plus inside, especially if the air conditioning doesn't work. We did try to sort of counter this with the fridges that we mentioned, and we bought some cool bags. And we tried to experiment with variations of the best methods. And the best one I could come up with was to use a fridge and take one of the cool bags out, and then halfway you switch them from the fridge to the cool bag. But it was very much a working process. So getting a sufficient sample, because we used capillary testing and not venous, we did find that we had quite a few sample failures. And that was a case of getting the blood out of the finger. We're dealing with patients who were peripherally shut down potentially in different environments. So it provided some difficulty. We considered venous testing, and the reason we sort of put it off was that we felt that we were adding in another invasive procedure when potentially it wasn't needed. And capillary testing, we would be blood sugar test patients who were experiencing chest pain anyway. So it was one test for two. To include the venous testing result would need more training, and it would also increase the on-scene time, which was a huge concern for our operational managers. The quality control process, again, was time-consuming. It was very labour-intensive to get the devices together. And one person to do it all would take a day to get them out, tested and back. Upscaling that to all our devices is a huge undertaking. Now, we talked about retaining paramedic involvement. Now, we did train around 75, 80 staff, and we did lose some. And when speaking to some of those staff, they mentioned that the process of getting the kit together was a barrier because it's not part of our established guidelines where once you sign on, you then go and get your point of care equipment. So it was an additional thing that they had to remember to do, not just at the start of the shift when they were getting fire jobs, but also during the shift to remember it was the people who struggled getting the sufficient samples would eventually drop out despite efforts to sort of reduce that as much as possible. So this isn't a new problem. We all know this with trial work that people who are involved, they will get worn out with it and then they don't want to carry on doing the test. So it isn't a unique problem to this pilot. So I have talked quite a lot about all the things that were problems with this pilot. It isn't all doom and gloom. So our aims at the start were, can this be done in the pre-hospital setting? So the answer is yes. And then can we create a pathway of testing chest pain patients? So again, yes, but a lot of work is required before we know that this is truly safe and start leaving patients at home. Rick's going to touch on the next stage of this, and I don't want to steal his thunder. So yes, we can do it, but it's not without its challenges. So I always add in this, I've done these presentations a couple of times now. I always add in that it takes a village, because it's, as was said earlier, it's not just me doing this. It's been a large group of people, and we have actually worked really, really well together. And that's our point of care village.